Are the meeting platform hosts ready to begin?
Yes.
Madam Chair, are you ready to begin the hearing?
Mr. Rosendale, are you ready? Yes.
Please perform your 5-second countdown.
5, 3, 2, 1. The committee will come to order. Quorum is present. Without objection, the chair is authorized to declare a recess at any time. The committee procedures for remote hearings remain the same. If you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so those issues can be resolved immediately. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteranaffairs.hearings@mail.house.gov. Without objection, members will be recognized in order of seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. Does any member have a question about the procedures for this hearing? Hearing none, we will proceed. I now recognize myself for an opening statement. Good morning. Thank you all for joining us today for the Health Subcommittee's legislative hearing. Before we begin, I'd like to ask unanimous consent for our colleagues, Representative Pappas, to participate in today's hearing should he be able to attend. Without objection, so ordered. I'd also like to welcome our full committee chairman, Mark Decano, and ranking member Bost. They will each offer remarks about their respective bills on today's agenda, and they may or may not stay to participate in the remainder of the hearing. But welcome, Mr. Bost, and I know Chairman Decano is going to be here shortly because his Perrier is on the table. Today's agenda includes a total of 6 bills, several of which are focused on addressing the healthcare needs of veterans. Importantly, we will discuss 2 of my bills that would increase veterans' access to family planning health care. H.R. 1957, the Veterans Infertility Treatment Act, would make infertility care part of health care at VA. For too long, infertility care in the United States has sat outside the scope of real health care. Most insurance plans don't touch it, and those that do rarely cover enough of the cost to make it possible for most families. Veterans who use VHA for their health care have similar barriers to care. VA's IVF policy, which is copied from DOD's policy, is only available to veterans whose fertility was caused by their service. Since 2018, VHA has made only 762 referrals for IVF, yet 1 in 8 people will experience infertility in their lifetime. And from what we know about infertility in the veteran population, the need among veterans is likely higher. Service connection is very difficult to prove for many conditions, but conditions like ovulation disorders, endometriosis, or sperm abnormalities. H.R. 1957 removes the service connection requirement and allows VA to treat infertility like any other medical condition. It would also remove the prohibition on use of donated embryos, remove the requirement of marriage, and expand access to LGBTQ veterans and single veterans. This bill is the result of years of advocacy by the witnesses before us today. Our veterans deserve to be made as whole as we can make them. For many, that means a chance at parenthood, or for others, the prevention of it. Providing veterans the full spectrum of reproductive health is the least we can do as a grateful nation. My other bill, H.R. 345, the Reproductive Health Information for Veterans Act, would explicitly require the VA to provide abortion counseling to veterans, even if the pregnancy is unwanted, unviable, or unsafe. Abortion care is health care. VA providers must be empowered to talk about all health care issues with their patients as any other provider outside of the VA would. While no current federal law explicitly bars VA from providing abortion counseling, the department has chosen not to provide this critical service based on its overly strict interpretation of existing law. Today's hearing is timely given the news we will soon be receiving from the Supreme Court. The overturn of Roe will have catastrophic and possibly deadly consequences for our veterans. Everything from IUDs to IVF will be impacted. Veterans with incomplete miscarriages, ectopic pregnancies, or just unwanted pregnancies will be forced to take their lives in their own hands without VA providers to help inform them and help them navigate a new landscape. For these reasons, we must advance both of my bills, H.R. 1957 and H.R. 345. We can't protect all American women from the impact of a post-Roe world, but we can protect veteran women. These bills are critical steps to protecting their health and their safety. In closing, I look forward to today's conversation and to receiving feedback from our witnesses. Your expertise and input are invaluable to us as we craft legislation. And with that, I'd like to recognize Acting Ranking Member Rosendale for 5 minutes for opening remarks he may wish to make.
Thank you, Chairwoman Brownlee, and welcome to Chair Takano and Ranker Bost. And good morning to all of our panelists here today. It's my pleasure to sit in for General Bergman as the ranking member of the Health Subcommittee today. He's otherwise occupied in the Armed Services Committee, which is meeting right now, marking up the National Defense Authorization Act, and he certainly sends his regrets to everyone. There are 7 bills on today's hearing agenda. Ranking Member Bost is sponsor of 2 of those bills. The first of his bills is H.R. 291, the Cost Savings Enhancement Act. It would require VA to install and operate on-site medical waste treatment systems at certain medical facilities. Regulated on-site medical waste treatment systems are a best practice. Using them in more VA medical facilities would benefit the VA and the environment, as well as saving taxpayers' dollars. That sure sounds like a no-brainer to me. The second of the ranking member's bills is H.R. 1216, the Modernizing Veterans Health Care Eligibility Act. It would establish a bipartisan commission to examine veterans' eligibility to enroll in the VA health care system. The last time VA underwent significant health care eligibility reform was 26 years ago in 1996. The world is a different place since then, to say the least, and it's past time for us to take another look at who we allow to enroll in the VA healthcare system and when. I thank Ranking Member Bost for introducing both of these bills. I look forward to discussing and supporting them. That said, there are bills on today's hearing agenda that I must strongly and adamantly oppose. H.R. 345 would require VA to provide abortion counseling. There is no other way to say this. This bill is radical and it's wrong. It's wrong for veterans, it's wrong for taxpayers, and it's wrong for the VA doctors and nurses. Most of all, it's wrong for the innocent, unborn children of our nation's veterans. Women are volunteering to serve in our country in uniform in record numbers, and quite frankly, they deserve better than this. No government or non-government organization should ever counsel women on where and how to seek an abortion. Instead, pregnant women and their children should be supported through pregnancy, childbirth, and every day after that. Our veterans fought, and some of them died, to uphold the values of life, liberty, and the pursuit of happiness for all American citizens. That most certainly includes the most innocent and defenseless of our citizens, the unborn. The other bill on today's hearing agenda that I must oppose is H.R. 1957. I want every veteran to have an opportunity to raise a family. My heart aches for those who are unable to. But I cannot support a process like vitro fertilization that creates life in a petri dish and then either destroys, discards, or forever freezes it on a shelf. That is not life-affirming. That is not right for veterans or their spouses or for their children. And that is not an appropriate use of taxpayers' dollars. I look forward to discussing other bills on today's hearing and our witnesses from VA and Veteran Service organizations. I thank you all for being here. And with that, Madam Chair, I yield back.
Thank you, Mr. Rosendahl, and we will now welcome our first panel, where we will hear from colleagues who have sponsored legislation on today's agenda. Chairman Takano, you are now recognized, and welcome. You are now recognized for 3 minutes to discuss your bill, H.R. 7589, the Remove Copays Act.
Thank you, Chairwoman Brownlee. I am pleased to speak on my bill, H.R. 7589, the Remove Copays Act. If enacted, this bill would eliminate veterans' copays for the first 3 mental health outpatient appointments they get at VA every single year. A simple step that will increase access to life-saving mental health care for our nation's veterans. VA leads the world in providing superior mental health care, and we know that veterans receiving care at VA are less likely to die by suicide than those who are not. And that is why it is vital to remove any and all barriers veterans may face when accessing timely, high-quality mental health care. Now, my bill lessens potential financial barriers to seeking and accessing outpatient mental health care at VA, making it more likely that veterans will get the care they need and deserve. This bill is part of a larger push by the Biden-Harris administration to increase access to mental health care for all Americans, and was specifically requested in the Department of Veterans Affairs fiscal year 2023 budget request. The Remove Copays Act would make VA the first federal agency to take this concrete step towards making mental health care more immediately available to veterans. Now, this legislation has garnered strong support from 15 VSOs and mental health advocacy groups. So thank you, Chairwoman Brownlee, for considering the Remove Copays Act here first in the Health Subcommittee, and I urge all my colleagues to support H.R. 7589. I yield back to my time.
Thank you, Mr. Chairman, and thank you for bringing forward a very important bill around mental health. So thank you for that. I now recognize Ranking Member Bose for 3 minutes to discuss your bills, H.R. 291, the VA Cost Savings Enhancement Act, and H.R. 1216, the Modernizing Veterans Healthcare Eligibility Act.
Thank you, Chairwoman Brownlee. It is, it's nice to be here with the Health Subcommittee today, and I'm grateful that my 2 bills are being considered this morning. The first bill of those bills is H.R. 291, the Cost Savings Enhancement Act. This bill would require VA to install on-site medical waste management systems at certain VA medical facilities. On-site medical waste management systems are considered a best practice by the Centers for Disease Control Prevention and the World Health Organization. And best practices are exactly what our veterans deserve. But only in a minority of about 20%, to my understanding, of the VA medical facilities have invested in an on-site waste management system. My bill would change that. In doing so, it would ensure that VA medical facilities are cleaner, safer places for our veterans to seek care and VA staff to work. It would also save taxpayer dollars. That makes it a win-win. Now, the other bill of mine today on the agenda is H.R. 1216, the Modernization Veterans Health Care Eligibility Act. This bill would establish a commission to assess veterans' eligibility for health care from VA and recommend how to improve on it. The current system governing eligibility for enrollment in the VA healthcare system was created in 1996, and that was a long time ago. And how we fight wars has changed since then. How we care for our wounds of war has changed since then as well. And the VA system, healthcare system, must keep pace with the times or risk failing veterans in today's world and for every generation to come. My bill would help us figure out how we can move forward without leaving any veteran behind. And I look forward to seeing what today's witnesses have to think about both of my bills and to working with all of the witnesses and subcommittee members to make them even better. However, like Acting Subcommittee Ranking Member Rosendale, I must rise in opposition to the 2 of the other bills under consideration today. Anyone that knows me knows that I'm proudly pro-life. To me, this isn't a political position. It is what I believe is right by my faith. I do not believe that VA should have anything to do with abortion or abortion-related services. The VA certainly shouldn't be telling veterans where to go to get abortions and abort their unborn children. Yet, that is exactly what H.R. 345 would require. As Congressman Rosendale said, this is wrong. Abortion is not health care, it's murder. That's why I do not support the legislation that imposes abortions or abortion counseling on women, or forces taxpayers to fund abortion or abortion counseling, forces pro-life VA doctors and or nurses to counsel veterans on abortion, or forces any pro-life health care provider to counsel patients on abortions and perform abortions, whether at VA, hospitals, or any other facility. Needless to say, I'm opposed to 345 in the very strongest terms. The other bill on today's agenda that I must oppose is H.R. 1957. The vitro fertilization involves the destruction of identified storage of fertilized embryos. That's also wrong. Being a father is one of the biggest highlight of my life. Now, I wish every veteran knew the joy of parenthood. And what I want to help veterans struggling with infertility to connect with life-affirming resources and support. H.R. 1957 doesn't meet that criteria. I hope to work with my colleagues and fellow veterans in the days ahead to find a better bill that does. And perhaps through snowflake adoptions or additional compensation for veterans who are unable to conceive, we can work through that if at all possible. But with that, I yield back.
Thank you, Ranking Member Boss. Before I move on, do any members of the subcommittee have questions for either Chairman Takano or Ranking Member Boss on their respective bills? Seeing none, hearing none, I would now like to introduce our second panel of witnesses from the Department of Veteran Affairs. Testifying before us this morning is Dr. Matt Miller, Executive Director of Suicide Prevention within the Veterans Health Administration. He is accompanied by Dr. Amanda Johnson, Director of Women's Reproductive Health in the Office of Women's Health at VHA, and Mr. Garth Miller, Executive Director of Member Services in the Health Eligibility Center at VHA. Welcome to all of you. I will remind our witnesses to please pause for 2 or 3 seconds before speaking so that the recording will capture all of your words, and please remember to do so again when answering questions. Your written statement will be included in full in the hearing record without objection. Dr. Miller, I now recognize you for 5 minutes for VA's remarks on the bills before us.
Good morning, Chairwoman Brownlee, Acting Ranking Member Rosendale, and other members of the subcommittee. Thank you for inviting us here to present information and feedback on several bills that would affect VA programs and services. VA is grateful for this committee's dedication to providing VA the authority and resources to maximize access, efficiencies, experience, and quality for veterans' health care, and in particular, mental health care and suicide prevention. As a veteran myself, and as are several members of this subcommittee, I can think of no higher calling or responsibility. As we speak, and with due recognition and credit to members of this committee, the wheels are well in motion for the implementation of the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant, for Mission Daybreak Suicide Prevention Innovation Grand Challenge, for 988 implementation at the Veterans Crisis Line, and for the continued spread of community and clinical suicide prevention interventions through Suicide Prevention 2.0. Since 2019, we have seen and are seeing hopeful trends in veteran suicide data, and we look forward to releasing our annual report in late summer, early fall of the present year. Yet there are no declarations of victory and certainly no celebrations. There is no good enough on this issue. As is true of many of you sitting here today, my connection with the mission of suicide prevention is personal. My motivation as the Executive Director of Suicide Prevention is not grounded primarily in policy or procedure, but instead by nuts. Nuts was the call sign for my colleague and my friend when I was the Chief of Mental Health, and he was a flight commander and instructor pilot at a Joint Services undergraduate military pilot training base. After serving 2 years side by side, Nuts was tasked for combat redeployment as a Marine Cobra driver. He died by suicide in visiting officer quarters. My focus, therefore, always returns to the means and mechanisms that can be enacted to treat, heal, soothe all wounds, internal and external, visible and unseen. In this context, we strongly support the policy goals of H.R. 7589, the Remove Copays Act, which would remove barriers to mental health for enrolled veterans and could help, in turn, reduce veteran suicide. VA's fiscal year 23 budget included a similar proposal on this issue, and we very much want to continue to work with you to ensure maximum veteran benefit through this bill. The same is true for H.R. 1957, the Veterans Infertility Treatment Act, which would help more veterans realize their dream of having a family. These represent areas of agreement where Congress and VA can work together to improve veterans' health care. We also would like to work with you regarding H.R. 345, the Reproductive Health Information for Veterans Act, to ensure that veterans can make their own decisions about their care. We have some considerations regarding the 3 other bills that will be discussed today. For 2 of these bills, H.R. 291, the VA Cost Savings Enhancement Act, and H.R. 6273, the VA Zero Suicide Demonstration Project Act, we are concerned about legislating specific requirements relating to contracting and procurement, as well as legislating specific clinical approaches via a specific contractor. Nonetheless, we see positive potential in this bill as well. Regarding H.R. 1216, the Modernizing Veterans Healthcare Eligibility Act, we understand the committee's interest in reviewing eligibility for VA healthcare. We do have some concerns, however, within the proposed text. My written testimony identifies areas where we feel we can work together to address specific issues related to eligibility for healthcare. We know each of the bills on today's agenda was developed by you with sole purpose of better serving veterans. I know we can work together to deliver upon our unified mission of delivering the best care for veterans. This concludes my testimony. We're happy to answer any questions you may have. Thank you.
Thank you, Dr. Miller, and I now recognize myself for 5 minutes of questions. So since Congress authorized the VA to provide IVF for service-connected infertility in 2017, nearly 800 veterans have been referred for IVF care. While we don't know how many of these referrals ended in live births, we know that some veterans are getting the treatment they need. My bill, H.R. 1957, would enable VA to create infertility in the same manner it treats any other health condition as part of the full spectrum of health care. So, Dr. Johnson, is it true, I just want you to confirm this, is it true that VA treats all infertility cases that are not service-connected except for IVF?
Yes, that is true.
So you see all the other treatments of infertility, so our veterans can have a family, as part of the whole health care provided by the VA?
Yes, that's correct.
So, Dr. Johnson, why not IVF?
IVF is explicitly prohibited to be provided in the Code of Federal Regulations, and in 2016, a law was passed that allowed us to provide IVF to specific veterans who meet very clear eligibility criteria.
No, I understand that. I
Right.
know what the current
Yep, right.
policies are. I'm asking why the VA, if you're doing all of these infertility treatments up to the point of IVF, none of them have worked. They don't have to be service-connected in order
Right.
for a veteran to receive those treatments. Why do you stop there and say IVF, you
Right.
have to have a service-connected reason for us to perform this so you can have a family?
Right, that's an excellent question. And it's not so much the service-connected piece that's hard about IVF. For IVF, in almost all cases, not in all cases, but in almost all cases, it requires treatment of a couple. So the veteran, VA has authority to treat veterans, that's part of our authority, but we really don't have authority to treat non-veterans except where we have specific carve-outs. And that legislation in 2016 allowed us to treat the veteran and the non-veteran spouse. Now, you're absolutely right. Those eligibility criteria include infertility as a diagnosis. It includes that service-connected condition or treatment for the service-connected condition must be causing the infertility. It also requires that veterans be legally married. And then it goes further to say that donor gametes, donor embryos, surrogacy would make that veteran couple ineligible. So the piece about why we aren't able to take it forward into IVF and ART is primarily about the limitation that we cannot treat partners except for that specific authority that we have and have had since 2016.
But if my bill became law, you would have that authority, is that correct?
That is correct. That would create
That's what
new
I'm
authority.
asking. We're talking about the bill that I've introduced.
Yeah.
That's what we're talking about.
Right.
I'm trying to understand why you oppose the bill. I understand that there's parts of it that you
Right.
do support, but the point of service connection to receive IVF is a place where you disagree.
Where we differ.
And I want to know why.
Right.
Because we will hear further testimony today that says that, abortion, IVF, infertility is a disease. It's part of health care. It should be treated like health care. Why do you not believe that?
Right. So you're absolutely right. VA does strongly support the intent of the legislation, and VA has actually included in the FY23 budget request a legislative proposal to expand access to IVF and enhance equity, particularly around that requirement to be married.
I understand.
Right. The piece about, and I understand what you're asking, the piece about service connection, it is our position that our proposal that allows people to use IVF and infertility services regardless of relationship status, regardless of need for donor gametes, but continuing to provide those services to those who have lost their ability to procreate related to their service or related to care rendered by VA really ensures that those who have sacrificed the most for our country receive the services they deserve.
Do you believe personally that infertility is a disease?
I believe personally that infertility would meet criteria for a disease. It prevents people from living their fullest, greatest health and lives. Absolutely, I'm an OBGYN.
And you don't believe that our veterans deserve the very best treatment in their health care?
VA strongly believes that that veterans deserve the very best in their health care. Absolutely.
And it just doesn't seem to be consistent with what you're opposing and what you're saying your beliefs are.
Right.
And, and that's the thing that I'm just trying to get at this.
Absolutely.
And you're answering my questions, and I appreciate it. But I just think that that's the most important point here, to underscore. You either believe that infertility is part of a healthcare system and it is a disease, or you don't. And we also know that service connection to infertility in many cases is very hard to determine.
It can be
Very,
very
very
challenging.
hard to determine. And we also know that, 80 or 90% of the infertility treatments that you already provide to a veteran will solve the infertility problem. But in some cases, the final and last treatment one can receive is IVF. And you're saying, no, you have to prove yourself that this is service-connected when we know it's really, really hard, very, very hard to absolutely determine if the service connection has something to do with your infertility. So that's just the point I want to make. I'm a minute over, and I will go to Mr. Rosendahl for 5 minutes of questions.
Thank you, Madam Chair. And I think that many of the statements that you just made actually bring justification to Ranker Boss legislation, Modernizing Veterans Health Care Eligibility Act. So we can go through and evaluate this and have a document that determines eligibility for a lot of these issues instead of having it piecemeal all over the place. So I appreciate that he's brought that forward. Dr. Miller, regarding H.R. 1957, the Veterans Infertility Treatment Act of 21, could you please explain the justification between a service-connected requirement and providing equity? We keep hearing this word equity to the same-sex veteran partnerships and single veterans.
Thank you for your question. I appreciate it. I'm going to defer to Mr. Miller, who is our expert panelist on eligibility as Director of Member Services. Thank you.
I'm sorry, could you repeat the question?
Sure, glad to. Could you please explain the justification between a service-connected requirement and providing equity to same-sex veteran partnerships and single veterans in regards to H.R. 1957?
Mr. Rosendale, is it okay if I take that question?
Absolutely.
Okay, thank you. What I'm understanding that you're asking is, what is the justification between having a service-connected condition and providing services to people who are single in same-sex marriages? Is that right? I don't know that those two are actually connected. They are part of specific eligibility criteria, and each one is an individual eligibility criteria. So, for example, a person could have infertility related to their service, for example, IED explosion. They could be legally married, but because of that injury sustained during an IED, they no longer have testicles and are no longer able to produce sperm.
That I sure understand.
Right. So for those veterans, even though they meet all of the other eligibility criteria, because they would need donor sperm, they are no longer eligible. And that was created by law in 2016.
Okay. All right, Dr. Miller, I'm going to move on. You note the absence of an adoption option in 1957. How would VA propose supporting adoption as a medical benefit?
Thank you for the question. I will defer to Dr. Johnson for this as well. Thank you.
Yes, thank you, Mr. Rosendale. And actually, one of the ways that VA's budget proposal, VA's FY23 budget request differs from HR 1957 is we include adoption and adoption reimbursement as an option for veterans. We know that for some people, even when they've gone through all of the infertility treatment and then have gone to IVF, it still may not be an option. And adoption really is the only option to allow veterans to achieve their dream of becoming parents. And we feel strongly that we need to include that.
And would that adoption benefit be limited to veterans who are unable to procreate due to a service-connected condition?
It would continue to keep those same requirements.
Okay. Let me see here. One, I'm going to go over here. To all the panelists, I'd like to, or whoever may be designated to answer this. In the absence of a service-connected disability that impedes procreation, should taxpayers cover family building with the inherent concerns about providing embryo preservation services in perpetuity as a health care benefit?
Okay, thank you. So there's a couple issues there. So VA does already support family building for all veterans, regardless of, marital status, regardless of sexual orientation, but it doesn't include creation of embryos until we get to assisted reproductive technology and IVF. VA has already authorized us, sort of consistently and repeatedly, to provide IVF services to those who have sacrificed the most, who are most greatly injured. VA does not own those embryos that are created. VA does not destroy those embryos. That is a personal matter, and that is up to state law. What VA does is we pay for the creation and we pay for the storage of those embryos.
Okay, and again, what we're talking about is preserving something in perpetuity. Do you think it's best use of limited taxpayers' dollars to support that effort?
I think anytime we're providing health care as an organization, we have to consider the unique needs of each veteran we serve, and this is one piece of that.
Okay, Dr. Johnson, under the VA's current authority to provide IVF treatments to service-connected veterans, how many referrals for treatment per year have been made on average over the past 5 years, understanding that the pandemic may have skewed some of these numbers a bit?
Sure, and you're asking about infertility or specifically the IVF and ART and service-connected infertility?
Yeah, the IVF.
Specifically? So we know almost 800 couples who have been referred for services. And so initially, we thought there may be some backlog in 2016, but I would say probably around 125 couples per year, if my math is correct, and my math isn't perfect, but it's about that.
Okay, I see my time has expired. Madam Chair, I'll yield back.
Thank you, Mr. Rosendahl, and I now recognize Mr. Levin for 5 minutes. Oh, excuse me, I apologize. I recognize the chairman of the full committee, Chairman Takano, for 5 minutes of questioning.
Thank you, Chair Brownlee, and thank you, Mr. Levin. And Chairwoman Brownlee, I just want to express my support for your groundbreaking legislation on making infertility a disease that's treatable by the VA, and we should treat it as such, and the equity it would bring to all the different kinds of couples. So I want to congratulate you on that legislation, and I certainly support what you're attempting to do in terms of getting abortion counseling. This is not abortions. There are so many circumstances under which a woman's health is certainly dependent on getting accurate information on the options. And we know that there are certain types of situations where a woman needs to know these to save her life. So I support both efforts on your part. Dr. Miller, I want to turn to my legislation. I understand the VA supports my Remove Copays Act, but has some substitute language from its general counsel. My staff have been working with VA staff and will be happy to make those technical changes. Will you be able to fully support the bill with those changes?
Thank you for your question, and thank you for the proposal that you have offered. We know that access to health care also entails breaking through common barriers. Common barriers can be unseen, like stigma, and they can be seen, like finances and bills. We believe that there are a few ways to improve the benefits that veterans will receive through your well-reasoned bill. We believe that includes talking through a little more detail regarding what types of outpatient mental health services to ensure, for example, services that occur within primary care are also included. We also think that maybe talking about episode of care coverage in contrast to 3 visits may be worth considering. In concept and with some language details, we are on board with what you're proposing.
Well, thank you very much for that. Can you also say more about why VA is averse to further piloting the zero suicide programming at other VA medical centers?
I want to state, thank you for the question. I want to state very clearly at the outset, we are not averse to zero suicide initiative, the 7 core tenets upon which they stand and center their programming around. We agree with the foundations and the principles. Back in 2018, as part of the Clay-Hunt Act, it was requested, it was stipulated that we perform an analysis of the VA approach to suicide prevention vis-a-vis the Zero Suicide Institute. We presented a crosswalk within the Clay-Hunt report, and since then, we've also added additional opportunities for improvement that crosswalk explored. One good example of that, I think, is universal screening. So in summary, we are not opposed. We feel that we are complementary and value added.
Okay, well, thank you. In a statement for the record, the Zero Suicides Institute notes that they have collaborated with the Manchester VA to add the Zero Suicide Framework into its existing VA suicide prevention priorities, and that VA leadership and staff consider it a great success. And so, inconsistent with that, are you saying that VA So I don't understand why VA wouldn't want to expand this pilot collaboration with other VA medical centers.
Yeah, thanks for pushing to that point. You're right that the Manchester VA did perform a pilot with zero suicide. They've discontinued that pilot. They have stated that it was successful in certain areas, such as helping to unify the facility as a whole around suicide prevention. There are other measures and outcomes as part of program evaluation that's comprehensive that are less conclusive, nonetheless are worth considering. We would look forward to an opportunity to outline all data and evidence as part of this discussion.
Well, I hope we can continue this discussion because I'm still, your response doesn't really give me a sense about why we wouldn't want to expand this pilot to other medical centers. I mean, you said a lot about other data. I'm hoping, I hope that you all work with the committee staff to sort this out.
We would be pleased to do so. Thank you.
All right, thank you. I yield back, Madam Chair.
Thank you, Mr. Chairman. I now recognize Ranking Member Bose for 5 minutes of questioning.
Thank you, Madam Chairwoman. Dr. Miller, for facilities that rely on off-site disposal, how is medical waste disposal impacted when faced with emergencies such as what we did with the pandemic, or even a weather-related type situation? So for those facilities that actually have off-site, how does that affect them?
Thank you for your question, sir, and we appreciate the work that you're doing with this bill. I am going to defer this to Mr. Garth Miller, although last time I kind of put you on the spot, Garth. Are you, okay, good.
Thank you, Ranking Member Bost, and thank you for your service as well. VA experienced a 20 to 30% decrease in regulated medical waste generated during the first 18 months of the COVID-19 pandemic due to transitioning to telehealth and halting elective procedures. So there are some caveats to that data. On-site treatment of regulated medical waste would be beneficial during an outbreak of monkeypox or Ebola. Regulated medical waste generated from patients receiving treatment for a potential Category A agent has stricter transportation and disposal requirements. So that's where the off-site treatment comes into question. On-site treatment would be beneficial during an emergency when regulated medical waste disposal services are interrupted. However, by treating regulated medical waste on-site, the waste is now converted to solid waste, which still requires being treated and being hauled off station to alleviate a healthcare sanitation issue.
Okay, with these systems, they actually incinerate, correct? And it is a solid waste, but it is better to transport in that manner or not?
There are, thank you for the follow-up. There are certain situations where that is in fact the case. There are some situations such as that would require facilities still to require regulated medical waste contract to manage, for example, pathological, animal, and trace chemotherapy waste, which is prohibited from being treated with steam sterilization. So to circle back, there are very different requirements at different facilities, maybe even
Based on the type waste?
Yes, sir. Okay. And you know, for an example, Birmingham and Tuscaloosa, they're 40, 45 minutes apart. Very different complexity, different types of procedures, different types of academic affiliations that lead to research. And so what we are concerned about is a prescriptive approach, putting across the entire enterprise one template, when we know that different markets and different infrastructure lead to different needs for the various facilities.
Mr. Miller, I think with my next question, I'm going to stay with you, even though the way it's written here was directed to Dr. Miller, because I'm going to figure he's probably going to send it to you because it's on the same question, kind of the same line. What specific concerns does the VA have about VHA's regulating medical waste on-site treatment equipment systems blanket purchase agreement? So if we buy them, what concerns do the VAs have if we go down this path and we're going to have uniformity between each VA?
Sure. Our policy encourages the networks and the medical centers to do feasibility studies and cost-benefit analysis for on-site treatment based on their unique needs. We do have a national contract. As you mentioned in your opening remarks, we're right around 20% of facilities that are utilizing that national contract, and we are adding more facilities right now. We have a step-by-step ordering guide to facilitate the equipment and procurement, but we do leave those local decisions based on the local market, the infrastructure, up to the network directors and the individual medical center directors.
Okay. Do you think there would be a cost savings if we looked over those agreements to try to figure out what they have in common and do it this way? I just as I watch all the amount of private sector hospitals that use on-site waste disposal and how it has been the best practice to do so, that each individual, you know, we deal with this and you use it, all of the people that work at the VA, and then we do too, and it's a terrible statement, but if you've seen one VA, you've seen one VA. But the reality is there are several things that can be united. Is there a possibility that we can look to try to do that?
I believe there is potential there. As I stated, there is a national contract already in place, and I don't claim to be a subject matter expert on the contracting vehicles. However, you know, our standard response is that we want to have open competition, we want to have free market, and that will result in the best tax savings, or the best use of our limited resources.
All right. Thank you, and my time has expired. Thank you. You're back.
Thank you, Ranking Member Bost. And Mr. Levin, it is absolutely your turn now. I recognize you for 5 minutes.
Well, thank you very much, Chair Brownlee. I too would like to commend you for your leadership and for the legislation today. Dr. Johnson, it's been widely reported that the Supreme Court is poised to overturn Roe versus Wade and Planned Parenthood versus Casey. And if true, this decision would trigger a patchwork of state restrictions that will make access to reproductive care far more complicated and far more difficult. That's one reason why I think it's so important that we pass Chair Brownlee's Reproductive Health Information for Veterans Act, which would ensure veterans can receive reproductive counseling from their VA healthcare providers. What are the consequences for veterans, particularly those with complicated health conditions or low incomes, if VA providers can't advise them of their options in this new landscape?
I think the consequences for veterans, if they're not able to have access to sort of the full range of information about their medical care, whether we're talking about pregnancy, whether we're talking about any other medical condition, the consequences are significant. It is our position that it absolutely improves veterans' health care if they have full information about their choices related to their care. We strongly support HR 345 for that reason.
Thank you for that comment. I want to shift to the Veterans Infertility Treatment Act. There's been discussion of the VA's IVF policy, so I don't need to repeat it, but it's fair to say that it excludes lots of different people, LGBTQ veterans, unmarried veterans, many others. How many veterans approximately currently fall in IVF coverage gaps that would be filled by the Veterans Infertility Treatment Act?
Right. It's hard for us to know that number partly because of the current restrictions. There may be veterans who don't apply for services, don't ask for benefits because they know that they do not qualify because they're single or because of their relationship status or because they know they would need donor gametes or embryos. So it's hard for us to identify. What we can say is we do have authority to provide fertility treatment, counseling, evaluation to everybody, all of our enrolled veterans, regardless of their relationship status, gender identity, sexual orientation. And so I think in one way, and I think Chairwoman Brownlee was sort of getting to this, we could use that potentially as a proxy to sort of estimate how many people need fertility services, and then a subgroup of those people would then need IVF and ART and need their partner to be treated. So if we use that as a proxy, I think we could say it's a little bit more males than females, and from 2017 to 2020, when we sort of looked at that time frame, it was about 7,500 male veterans, and it was about 5,500 female veterans who had any infertility diagnosis, treatment, whatever, from VA. So I think you could use that as a reasonable proxy.
Got it. That's very helpful. Thank you for that. I noticed a 2019 study of VA-enrolled women found that racial minority veterans were more likely than white veterans to self-report infertility, but less likely to report receiving infertility treatment. How do the current limitations on VA infertility care contribute to those disparities?
Well, those disparities are inherent in our healthcare system. So the limitations that we have in terms of our treatment absolutely impact people of color, primarily because we have to think about the population we serve, right? Women veterans are more likely to be non-white compared to the general population, and so anytime there are those racial disparities, you can only imagine that inequities sort of compound on each other.
Well, I appreciate very much your thoughtful answers and for the work that you are doing for our veterans. And with that, I'll yield back to Chair Brownlee.
Thank you.
Thank you, Mr. Levin. I now recognize Mr. Elsey for 5 minutes of questions. No questions. Then I will go to Ms. Frankel if she is still with us. She was just there a minute ago, but I'll take a few minutes of her time before we move on to the next panel. There's just, you know, really one more. Oh, I see Ms. Miller-Meeks here. I apologize. Ms. Miller-Meeks, you are recognized for 5 minutes.
Thank you so much, Chair Brownlee, and I thank all of our witnesses who are here today for us. I'm a 24-year military veteran, so this hearing is of interest to me, and I'll also say that I'm a supporter of the Hyde Amendment, where federal funding does not go to fund abortion. Dr. Miller, in 2016, the Bipartisan Commission on Care specifically recommended that, quote, the President or Congress task another body to examine the needs for changes in eligibility for VA care and or benefits, end quote. Given that eligibility criteria have not been holistically examined in 26 years, please explain VA's opposition to H.R. 1216, the Modernizing Veterans Healthcare Eligibility Act, and why you think that Congress should continue to address eligibility in a piecemeal manner.
Thank you for your question. Thank you for your service as well. Mr. Miller?
Again, thank you for your question, Representative Miller-Meeks. And VA has several concerns with the proposed bill and opposes it as currently written. The intended outcome of the commission is not clear. Depending upon the composition and focus of the commission, it may recommend narrowing eligibility or expanding eligibility, or both, but in different ways or for different rationale. We're particularly mindful of the potential effects changes to eligibility may have on our current beneficiaries. We would appreciate the opportunity to discuss with the committee any of the underlying concerns involved in motivating this bill, as we may be able to identify alternatives to strengthen the system or make the committee aware of ongoing changes and improvements we have with our eligibility system. For example, we have previously recommended to the committee that we engage in discussions to address complexities associated with VA's emergency care reimbursement authorities. Conducting a comprehensive assessment of eligibility may be complicated given the uncertainty of how these efforts will unfold. This may again suggest the value of a more focused approach. We believe flexibility, particularly regarding military environmental exposure, is very important, and we are keeping an eye on the PACT Act legislation. We believe that a single standard for eligibility in this area could prove inadequate to the future needs of veterans and their families. And I thank you again for the question.
So would that mean that you support the other bills that we're discussing today that expand eligibility if you're concerned about being able to provide care to the veterans to whom we're providing care currently, i.e. H.R. 1957? A service which is currently not provided, for which the VA does not have expertise, either in abortion or in fertility treatments.
Yes, we're in favor of producing the right results for veterans. We are aware that we have limited resources available, and we are looking at key areas where expanding healthcare can have immediate impact, specifically on those areas that may have been previously underrepresented or previously been ineligible due to outdated policies such as don't ask, don't tell.
So I'm confused. I'm just a simple doctor and a simple veteran in a rural area. And so you're in support of certain policies, but you're not in support of modernizing Veterans Healthcare Eligibility Act, which would also have the effect of offering services to populations that have been underserved.
I don't want to mischaracterize what I was saying. I'm very proud of the work that under this committee, the greater committee as a whole, that we have done to modernize eligibility and enrollment and to expand eligibility and enrollment. The concern that we have with this particular bill is the formation of a commission that may be unclear as far as what the underlying results or the drive of that commission would be.
I think that's exactly why an eligibility commission could perform a valuable service. And I think that an effort to refine multiple, complex, often competing standards and rules and bring them into the 21st century would ultimately be of greater benefit to a greater number of veterans such as myself. Thank you, Madam Chair. I yield back my time.
Thank you, Ms. Miller-Meeks. And I believe that Mr. Pappas is trying to join us remotely, but before we move on to the next panel, I just wanted to ask two more quick questions. And Dr. Johnson, a third of all fertility cases are unexplained infertility. So can veterans with unexplained infertility currently receive IVF through the VA?
That is a very good question. At this time, people cannot be service-connected for unexplained infertility. However, we are working closely with VBA on being able to better capture those people who did experience infertility that was unexplained during their service so that we can continue to provide services and expand services.
So if it's unexplained, we're certain of the infertility.
Right. They've sought the care.
But we can't quite determine whether it's service-related. We lean on the service-related side versus
It's a significant
veteran really
challenge.
deserves the hopes and dreams of a family.
Right. It's a significant challenge.
Second, I understand the sensitivity of avoiding the issue around cost because we know that IVF is relatively expensive. Not, it's the population is not huge, but when they receive IVF services, it is more costly. So, and I actually don't know whether it's more costly than some of the other treatments that are done within the VA. That I think is an important piece of information. But relative to cost, what we do know is 72% of veterans with infertility are in the priority group 1 area, which means, they're 50 to 100% disabled. Mm-hmm. So if they're infertile, regardless of, service connection or not, the VA is going to pay either almost 100% of the cost of that or, a large portion of that because they happen to fall into this category. So if cost is an issue, I think if we really drilled down on how much more expensive it would be, I think it's relatively insignificant. And I just wanted to you can disagree with that or agree with that, but I think it's important to make that statement that, for any disabled, for 72% of the infertile cases out there, they all fall into the category of priority group 1, which is 50 to 100% disabled and reimbursable. So I just wanted to point that out. I do not see Mr. Pappas, but I do see Ms. Underwood. So Ms. Underwood, you are recognized for 5 minutes. Welcome.
Well, thank you, Madam Chair. Thank you to our witnesses. I don't have any questions or remarks today, but I appreciate the recognition. I yield back.
Thank you. And is Mr. Pappas coming? Chairman Takano.
Yeah, I do want to ask an additional question, a couple questions. So, Mr. Miller, regarding the HR 1216, the Modernizing Veterans Healthcare Eligibility Act, by Ranking Member Bost, would you agree that the timing of this bill is maybe not very logical, given that first, the Congress is about to pass the PACT Act, which was informed by the current VA healthcare eligibility criteria, and second, that VA has just completed nationwide market assessments and issued hundreds of medical facility realignment recommendations that will be considered by the VA Asset and Infrastructure Review Commission as mandated by the Mission Act of 2018.
Thank you, Mr. Takano. I will defer to Mr. Miller, Garth, for a response. Thanks, Garth.
Thank you, Chair Takano, and I understand your question that you're asking. We do have a keen eye on PACT Act regarding, specifically regarding military environmental hazards, as well as effects that may have on fertility and on some of these other issues that we are discussing here. We are, as you know, very actively pushing out the findings of the Air Commission report, and we do look forward to that commission being seated with all participants, and we are looking forward to participating along with that. It does call to me, you asked about the timing. I would have concerns moreover about how we work with commissions versus how we work with committee and committee staff, and the formation of yet another commission for eligibility and enrollment. We just don't agree that that's the most effective way to make some of the changes that the greater committee, as well as DAMA and as well as HVAC, have been working with us for many years directly on trying to improve the enrollment system and the eligibility determinations.
Thank you for that response. Dr. Johnson, regarding the cost of IVF, just to put it in perspective, I've heard that relative to procedures like an appendectomy, that IVF is less costly than an appendectomy. Is that accurate?
I think it's hard to characterize, but I think what you're trying to do is put in the context of greater healthcare costs, and it's legitimate healthcare costs. You know, healthcare is expensive, regardless of the condition that we're treating, and I think it's appropriate to put fertility treatment, including IVF, into context. I don't know, I mean, it kind of depends on if it's laparoscopic or open, but I would say it could be comparable. Every family is different, so the numbers of retrievals, the numbers of cycles that they need can sort of really be reflected in the cost. You know, one of the things that's challenging is it can be hard to put a cost on healthcare for any condition, and that's true for fertility as well.
Well, I understand that. I just wanted to put it into context. Because most of us would regard an appendectomy as, you're getting your appendix taken out, not a very complicated procedure, and it's commonly done. It's considered part of healthcare.
Correct.
And, as far as, VA's ability to offer this option to a very circumscribed number of veterans, how many people are actually enrolled in VA? You may not know that offhand.
8.7. I heard 8.7 and 9 million. So somewhere.
Actually enrolled and then uses it.
It's a small number.
And the numbers that you gave in terms of who actually would be eligible under Ms. Brownlee's bill is in like the thousands. Like you said, 7,000, and then there's a subgroup that would potentially
need IVF and ART.
We're talking very small numbers of people, and the cost, more or less, per couple would fall in line with an appendectomy. Of course, there are some appendectomies that are more expensive.
Sure.
Some people who would use IVF, it would involve more cost, but we're talking about a very circumscribed number of people, and I think most Americans would say that those who are serving the military would merit this as part of just healthcare. You know, infertility treatment is just part of healthcare. I yield back, Madam Chair.
Thank you, Mr. Chairman. And Mr. Rosendahl, recognize you for a few more minutes of
Few more minutes.
questioning.
Thank you very
Yes.
much. Thank you very much, Madam Chair. Dr. Johnson, would VA interpret H.R. 345, the Reproductive Health Information for Veterans Act, to require abortion counseling for all veterans seeking maternity care?
VA interprets HR 345, and there are a few components of HR 345, and there are areas where we would like to work with the committee to improve the language, but VA interprets that as the ability to counsel. At this time, VA, in the Code of Federal Regulations, is not able to
Exactly. So
counsel or
if you
provide
interpret
services.
that to allow.
To allow
So
provision
that
of full reproductive
goes
health
right to the
counseling.
point that I want to make. 2 points, actually. Who's going to make the determination about who gets abortion counseling services and who doesn't get these counseling services? And the other point is, if so, how would counseling, so to speak, pregnant veterans, okay, about how to abort their baby, how could that possibly be considered empowering and not extremely offensive to someone who wants to raise and rear their child?
Right. So abortion counseling, how we really see that is the ability to provide the full scope of information about reasonable, legal, safe treatments available to
understand,
veterans.
but again, you're telling me that you're going to have to make the determination about who gets these abortion counseling services. Are you going to inquire? Are you considering an abortion? Do you not want your child, as a veteran comes in, to make those determinations? Or are you just going to have to deliver this information to everyone? And how can you tell me, when we sit here meeting after meeting and hearing after hearing, trying to create a warm and welcoming environment to all veterans, to tell me that that's not going to be completely offensive to someone who wants to keep their child?
Right. So these are typically conversations that have between a particular individual person and their provider at the time of diagnosis or the time of recognition. It really is individualized, just like it is for any other treatment, whether it be erectile
But somebody's
dysfunction,
going to
which
have
is
to make that
very
determination
private.
about who gets that information and who gets that counseling and who doesn't get it.
Well, that is true, and that is also true for every other health condition, right?
No other condition that I'm aware of has a conversation about ending a life of a child.
But
Okay?
every conversation between a medical provider and their patient does talk about the risks and benefits of each course of action for every treatment, every
There is a
medication, every
huge
surgery.
difference between
everything
having a
that we do.
conversation, okay, about stitches or about ending the life of a child. I'll yield back, Madam Chair.
Thank you, Mr. Rosendahl. Before we move on to the next witnesses, Mr. Lamb, you are recognized for 5 minutes.
Thank you, Madam Chair. I appreciate it. I really only have one main question, which is for Dr. Miller. And I apologize if I missed this already, but do you have any idea how many veterans are going to benefit from the elimination of copays for mental health treatment? I know it's something I've heard a lot about in my 4 years here, and I was just curious if you guys understood the overall impact of that.
Thank you for the question. We appreciate it. I think that as currently written, when you're looking at 3 outpatient visits and it's within a defined stop code series, it's called. I believe that the cost analysis on that has been calculated and generated and was submitted as part of our technical assistance comments. Offhand, I would defer to that submission, however.
Okay, yeah, if you could make sure we get a copy of that, I'll I'll ask my staff to look for it as well. But do you believe that this change will actually lead to an increase in veterans taking advantage of these services?
I think so. We take a look at, for example, an initiative that we engaged with in the last year and a half, when we found out that debt notification letters, collection letters, were going to be sent out to veterans. We asked the question. The question was, how many veterans are going to receive this letter and are already high-risk flag for suicide? There was not a procedure in place for then minimizing risk in those situations. So we developed a process between VBA and VHA where VBA coordinates with us information about who's receiving a letter. We match that with high risk status, and then we flag specific veterans at facilities who are going to be receiving those letters, so that the care teams can work with the particular veterans and help to minimize the risk. And that was a meaningful, when it comes to suicide prevention, you know this, sir, but one is meaningful, but there was a meaningful population that was involved in just that. And a big part of that was their copayments. So,
and is that effort continuing? What you just described, is that a permanent policy change?
Yes.
Great. Well, thank you for that. That's exactly the kind of thing you should be doing, that you probably won't get any credit for because you're actually avoiding bad things happening in the first place. But that's why you do this job. So thank you very much for what you're doing. Madam Chair, I yield back.
Thank you, Mr. Lamb. And just before we go on to the next panel, I just want to make a clarification, Dr. Johnson, with regards to Mr. Rosendale's comments. We're not requiring, if a patient does not want to talk about abortion, and that is not her choice whatsoever, the provider doesn't have to then keep pushing on, abortion if that's not what she wants to talk about, that she's made a choice, that she wants to have her baby. Now, it might be that in a case of the mother's life, the provider might bring up, this issue, but barring that, this is not about forcing anything.
Absolutely. It's not a requirement. It allows people to give full information, but it's not a requirement. You're absolutely right, and these are nuanced conversations.
Thank you very much, and we thank all of the witnesses for your testimony today, and we will now turn to our third panel. Our VA witnesses are certainly welcome to remain and listen to other stakeholders' testimony. So we'll invite panel 3. So welcome to our third panel, and we are so pleased to have all of you here and your range of expertise with us today. As I said in my opening comments, your insights on these pieces of legislation are truly invaluable, so thank you. Our witnesses are Ms. Joy Elam, National Legislative Director of Disabled American Veterans, Ms. Julie Howell, Associate Legislative Director at Paralyzed Veterans of America, Ms. Tammy Bartlett, Deputy Director of the National Legislative Service at Veterans of Foreign Wars, Ms. Lindsay Church, Executive Director of Minority Veterans of America. And finally, and last but not least, Ms. Barb Calora, President and CEO of Resolve, the National Infertility Association. Your written statements will be included in full in the hearing record without objection. Ms. Elam, we'll begin with you. We now recognize you for 5 minutes for your remarks on the bills before us. Welcome.
Thank you. Chair Brownlee, Acting Ranking Member Rosendale, and members of the subcommittee, thank you for inviting DAV to testify at this legislative hearing. I will focus my remarks on the bills under consideration today that most impact service-disabled veterans. H.R. 7589, the Remove Copays Act, would eliminate copayments for 3 VA outpatient mental health appointments per year, thereby allowing veterans who need these critical services to be relieved of the associated financial costs. It is incumbent upon VA to help ensure at-risk veterans do not encounter barriers to health care, and have access to needed mental health treatment to stay safe. Some veterans may require more intensive mental health services, therefore we recommend not limiting the number of visits exempted from copayments, which will benefit veterans with the greatest need for care. With the aforementioned recommendation, and in keeping with DAV Resolution 019, DAV is pleased to support this legislation. DAV also supports H.R. 6273, the VA Zero Suicide Demonstration Project Act, legislation that would require VA to establish a pilot program to assess the use of behavioral mental health care model based on the Henry Ford Zero Suicide Program. VA already incorporates many of the aspects of this model of its care for veterans at risk for suicide, and as a learning organization, it endeavors to continually improve safety by assessing adverse health care events. While there are some indications that VA is slowly turning the tide on this epidemic, this pilot program offers VA an opportunity to address systemic gaps in care for veteran patients who are at risk for suicide and to compare differences between existing prevention models, best practices, and related health outcomes. H.R. 1957, the Veterans Infertility Treatment Act, would make infertility treatment a part of VA's healthcare benefits package, allowing a full spectrum of infertility treatments and preservation services to veterans and their partners. DAV is pleased to support this bill in accordance with DAV Resolution 005, which calls for us to support legislation to improve veterans' access to assisted reproductive technology for all service-related conditions that affect procreation regardless of marital status. H.R. 1216, the Modernizing Veterans Healthcare Eligibility Act, would establish a special commission to examine existing statutes and policies guiding eligibility for veterans' health care. Our government has established a comprehensive package of benefits and health care services for those who have served our nation. For most veterans, access to VA health care is a critical component for a successful transition from military to civilian life, especially for veterans who have injuries and illnesses as a result of their service. And over the past decade, there has been a particular focus by Congress on ensuring that all veterans who need access to care, especially for post-deployment mental health challenges and most recently toxic exposures, can access the care they need. DAV does not support this legislation, as Congress has full authority to modify eligibility requirements or VA's medical care benefits package through the legislative process. And we believe that this subcommittee is best informed to make those decisions. Veterans will be best served by Congress conducting oversight of VA's often complex health care eligibility rules and legislating changes it deems necessary, rather than relying on less knowledgeable members of a commission to make such recommendations. Finally, H.R. 345, the Reproductive Health Information for Veterans Act, would require VA providers to offer abortion counseling for veterans with unwanted pregnancies, to include healthcare options and provider information for accessing such services. DAV does not have a resolution and takes no formal position on this bill. However, we do offer the following comments. The cornerstone of quality healthcare is trusted, open communication with one's healthcare providers, and it is important for a veteran to have candid dialogue with their medical provider pertaining to any condition, treatment, or procedure that impacts their health, regardless of whether services are provided by VA or not. This is especially critical in the case of pregnancy, as it could have serious effects on physical and mental health, particularly for veterans with disabilities. Chair Brownlee, this concludes my statement, and I'm happy to answer any questions you or members of the subcommittee may have. Thank you.
Thank you, Ms. Elam. And Ms. Howell, you are now recognized for 5 minutes.
Chairwoman Brownlee, acting ranking member, Representative Rosendale, and members of the subcommittee, Paralyzed Veterans of America would like to thank you for the opportunity to discuss our views on the bills before the subcommittee today. In the interest of time, I will focus on 3 of the bills up for review, and our remaining opinions can be found in my written statement. First, H.R. 1216, the Modernizing Veterans Healthcare Eligibility Act, which would create a bipartisan commission to assess veterans' eligibility for VA healthcare and recommend ways to revise and simplify eligibility for consideration by VA and Congress. As written, this bill lacks clarity on why such a panel is needed right now. Recent efforts to reduce the number of veterans who are eligible to receive VA healthcare, limit the types of medical services provided, or privatize VA healthcare have been repeatedly dismissed by Congress and outside experts alike. We believe Congress should continue to exercise its exclusive authority to conduct oversight of VA healthcare programs, including eligibility. Second, PVA supports H.R. 6273, the Zero Suicide Demonstration Project Act of 2021. Every person in this room likely knows at least one veteran that has died by suicide. Addressing veteran suicide requires VA to undertake a comprehensive approach to this crisis. The Zero Suicide model is a system-wide approach to mental and behavioral health services and aims to improve outcomes and close gaps in care. Healthcare systems using this model have seen dramatic reductions in the rate of suicide among their patients. We believe that this pilot program will help to test whether this model could be of help for our nation's veterans. The remainder of my comments will focus on H.R. 1957, the Veterans Infertility Treatment Act of 2021. If passed, this bill could transform the lives of many veterans living with infertility. Infertility is a condition that affects many veterans who have suffered injuries or illnesses in service that have compromised their ability to have a family. For veterans who served in Iraq and Afghanistan, genital injuries were higher than in previous wars. These injuries can result in medical and psychological trauma that can affect a veteran's ability to procreate. In 2016, VA was authorized to provide in vitro fertilization, or IVF, to veterans with service-connected infertility diagnosis. With continued support from VA's yearly appropriations, these services have continued to be available for eligible veterans. However, that funding is not guaranteed, and this transformative benefit continues to need yearly congressional action to ensure service-connected veterans are able to access IVF at VA. VA should recognize infertility in the same manner as any other medical condition. Under H.R. 1957, treatment for infertility would finally become part of the regular medical benefits and services package available to veterans who are enrolled at VA. Several of our PVA members were able to have a family thanks to IVF. I'm going to share the story of one of our members who was injured in an IED blast in Afghanistan when he was only 19. After his discharge, he met his wife, and they were eager to start a family. But because he could not produce viable sperm because of his injury, they had to seek outside care for their IVF services because of a prohibition of donated genetic material. As a result, this veteran had to seek out, I'm repeating myself. This cost that family $35,000, and that's despite his injury being directly related to his service. The current prohibition on using donated genetic material directly impacts veterans with catastrophic disabilities who also have an infertility diagnosis. When someone joins the military, they undergo significant medical examinations to determine whether or not they are physically capable to perform those duties. If that service member becomes injured or ill in service, our nation's sacred duty is to do whatever we can to make them whole again. H.R. 1957 would ensure that these veterans can access needed donated genetic materials to help them fulfill their dreams of having a family. We urge Congress to pass this critical legislation this year. Thank you again for the opportunity to discuss our views on the bills considered today, and I look forward to working with you on this legislation, and I'm happy to answer any questions.
Thank you, Ms. Howell. I understand this is your first time testifying. You did an excellent job. So thank you for that. Ms. Bartlett, you're now recognized for 5 minutes.
Chairwoman Brownlee, Acting Ranking Member Rosendale, and members of the subcommittee, on behalf of the men and women of the Veterans of Foreign Wars of the United States and its auxiliary, thank you for the opportunity to provide our remarks on these important pieces of legislation pending before the subcommittee today. The VFW's views on all 6 bills can be found in my written testimony, and I will take the opportunity to highlight 3. The VFW supports H.R. 1957, Veterans Infertility Treatment Act of 2021, which would require VA to amend its current IVF eligibility criteria to assist infertile veterans, regardless of their marital status and inability to produce gametes and embryos, to create the hope of enjoying one of life's beautiful gifts. A VFW member recently shared her struggle with infertility. She always saw herself as a mom, but waited to get pregnant until she completed her 10-year military service. Soon after her service, she began a committed relationship. But trauma from a first marriage and a horrendous divorce left her uneasy and unwilling to enter into another marriage, although she desperately wanted a family with her partner. Her depression deepened after 2 years of trying to conceive without success. Her VA provider began the process of diagnosing any infertility. The veteran endured months of multiple blood tests, x-rays, pelvic exams, extensive ultrasounds, only to find out she had damaged fallopian tubes. In vitro fertilization treatment would be their best option to having a family. But because the veteran was not married to her significant other and could not prove the infertility was service-connected, the couple was ineligible for VA's IVF treatment. The existing VA guidelines for IVF treatment eligibility are stringent and outdated, exclude certain veterans from using this program to achieve the dream of having a family without the financial burden. Being a parent grants the opportunity to invest in humanity, influence the future, leave a legacy, and enrich the family unit. But those who battle infertility, this is not a reality. The VFW supports H.R. 6273, VA Suicide Demonstration Project of 2022. Because it is an evidence-based suicide solution, this multi-layer approach consists of continuous suicide screening at all healthcare touchpoints, creating a crisis plan, and maintaining consistent communication with the veteran. Removing the stigma of discussing suicide and fostering a healthy conversation can lead to the end goal of 0 suicides. VHA has a unique opportunity to support all VA providers with the tools and knowledge to screen their patients for suicide at every appointment. From the national level to the post level, the VFW continues to do more for veterans, including supporting innovation in suicide prevention. For veterans who visited VHA, between 2017 and 2018, the suicide rate decreased by 2.4%. At the same time, the suicide rate of those who did not seek VHA care increased by 2.5%. Reducing the number of service members and veterans who die by suicide has been a priority of the VFW and will remain so until it is no longer needed. Although the data recently released by VA shows a slight decline in veteran suicide from 2019, the number must be reduced to 0 and remain there. However, VHA data alone does not provide the broad impact of VA services that can have on veteran suicide prevention. The VFW insists that VA's National Veteran Suicide Prevention Annual Report should include VBA data on non-medical services and programs that influence physical and mental health outcomes, such as education, job stability, stable housing, and food security. By identifying veterans who die by suicide and may have used VBA programs, we can gain a clearer picture of outcomes, spotlight areas that may need rigorous outreach, and provide additional funding when required. The VA's annual suicide report needs to capture all aspects of VA's impact on veterans and their families, to continuously identify barriers and challenges that remain, and not focus solely on their healthcare needs. The VFW supports H.R. 7589, The Remove Copay Acts, which would grant veterans first 3 VA outpatient mental health outpatient appointments without copays. This legislation fulfills VA's proposal to change the elimination of this barrier to care and increase veterans' access to mental health services. Veterans who do not have service-connected disability ratings of 10% or higher are charged a copayment for outpatient care not connected to their military service. Mental health care falls into specialty care, costing $50 per appointment. Financial burden should not prevent a veteran from seeking VHA mental health services. The VFW supports VA as it continues to expand eligibility for IVF services, pursue evidence-based suicide prevention programs, and eliminate barriers to mental health services. Chairwoman Brownlee, Acting Ranking Member Rosendale, this concludes my testimony, and I'm prepared to answer any questions the subcommittee may have.
Thank you, Ms. Bartlett. Mixed Church, you are now recognized for 5 minutes.
Chairwoman Brownlee, Acting Ranking Member Rosendale, and members of the subcommittee. My name is Lindsay Church, and I'm the Executive Director of Minority Veterans of America. Our organization works to create belonging and advance equity and justice for over 2,800 members and advocates for the unique needs of more than 10.2 million minority veterans across the country and world. We are grateful for the opportunity to provide our community's perspectives and concerns of the legislative matters. On today's agenda are several bills, which we provided a full list of inputs in our written testimony. I'd like to focus my opening remarks on bills impacting reproductive health, HR 345 and 1957. The VA has declared a mission of serving veterans by providing the highest quality healthcare available anywhere in the world, because America's veterans deserve nothing less. It's painfully clear, however, that the VA continues to fall short of its mission when it comes to comprehensive reproductive healthcare and family planning services as a result of statutory regulations. To receive even basic reproductive health care, veterans must navigate multiple medical systems and are forced to pay out of pocket even for essential life-saving health care. These administrative and financial burdens disproportionately impact populations that already experience disparities when accessing care, namely women veterans, especially women of color and unmarried women. Women veterans are the fastest growing demographic of veterans that VA seeks to accommodate care for, yet VA, as a matter of policy, does not provide care for their basic reproductive health needs. Women veterans in VA care are more likely to have an abortion when compared to their non-veteran counterparts, particularly if they are poor, experiencing housing instability, are unmarried, or recently gave birth. Out-of-pocket costs for abortions, which can be up to $1,000 depending on how far along the patient is, cause tremendous strain on veteran households and may be out of reach for far too many. HR 345 would empower women and birthing veterans with the information necessary to fully understand their options when it comes to their pregnancy. The current prohibition of abortion options counseling endangers the lives of veterans. Allowing pregnancy options counseling will bring the VA in line with the evidence-based healthcare being practiced in exam rooms across the nation. Options counseling provides critical health information to pregnant veterans and discusses continuation of pregnancy with the intent to parent, continuation of pregnancy with the intent to adopt, and pregnancy termination through abortion. Resources for care are provided based on the veteran's choice from these options. It's as simple as this. Abortion is basic health care, and veterans deserve access regardless of where they live, their socioeconomic status, or their circumstances. As long as VA declines to provide that care, veterans are unable to make the best decisions for them and their families. We strongly encourage the committee to expand today's proposed legislation to reverse the ban on VA-provided abortion services, including both medical procedures and medication abortions. As abortion access continues to be further out of reach for many veterans, particularly in some states that have a lot of veterans, agencies such as the Department of Veterans Affairs can provide essential reproductive healthcare services. Comprehensive reproductive health care, including abortion care, is a necessary aspect of the complete health of any veteran, any individual who can become pregnant. Lack of access to safe, timely, and affordable abortion care poses a risk to not only the physical, but also the mental and social well-being of those who can give birth. Infertility issues also deeply impact the veteran community. Despite the higher prevalence of infertility in the veteran community, veterans are comparatively less likely to receive infertility care. According to some studies, only half as likely. This result is not surprising, given that the benefit is available almost exclusively to couples that are cisgender, heterosexual, and married. Eligibility criteria categorically exclude same-sex couples, unmarried women, non-binary veterans, and trans men who want to conceive, even if their fertility is related to their infertility is related to their service. It also includes or excludes individuals and couples with non-service connected infertility conditions, including some trans and non-binary veterans, myself included. The current policies are not only prohibitive to historically marginalized minority veterans, but are restrictive for the entire veteran community. So restrictive, in fact, that only 567 eligible married couples have received IVF services through the Department of Veterans Affairs between 2016 and 2019. We strongly support HR 1957, which would provide more complete and comprehensive reproductive health care for our nation's veterans. We suggest that language be added to make clear that covered veterans without an intact uterus, such as gay men, trans women, and cisgender women who have had their uterus removed, may still access the benefit and we're grateful that this would include explicitly be offered to single veterans. Those who served raised their right hands and vowed to support and defend the Constitution of the United States and the rights that are offered to each citizen. It is now time for us to ensure that veterans are able to access these same rights that they fought for and expand access to comprehensive reproductive health care, protecting not just their lives, but their quality of life. Thank you for the opportunity to testify today. I look forward to answering your questions.
Thank you, Ms. Church. And finally, Ms. Kalura, you are now recognized for 5 minutes. Welcome.
Welcome. Thank you, Chairwoman Brownlee and Acting Ranking Member Rosendale. I'm very honored to be here. I want to discuss H.R. 1957, the Veterans Infertility Treatment Act of 2021. This bill does two important things related to the ability of a veteran to build their family. First, it requires access to infertility medical treatments for a covered veteran or a partner of a covered veteran. And secondly, it requires access to standard fertility preservation services to a covered veteran or a partner of a covered veteran. I'm the president and CEO of Resolve, the National Infertility Association, a nonprofit patient advocacy organization founded in 1974. We know firsthand the profound impact an infertility diagnosis can have on someone. And we also see the struggles of people who want to be parents but can't because they can't access the care that they need. Our community is millions of Americans, including our veterans. This bill is desperately needed today at the Veterans Health Administration because it is prohibited by regulation from offering access to medical treatments such as IVF to enrolled veterans. Since 2016, some veterans with a specific service-connected injury can access care. However, this is through an annual appropriation from Congress, must be renewed every year, and is extremely limited in who can access that care. We believe the VHA needs to take a different approach, and H.R. 1957 does just that. As America's largest integrated healthcare system, providing care to 9 million enrolled veterans, the VHA is expected to provide the most current standard of care to veterans experiencing any health condition or disease. Infertility is a disease, as recognized by the American Medical Association, the World Health Organization, the American College of Obstetricians and Gynecologists, and the American Society for Reproductive Medicine. Just like any other disease, the VHA should provide access to care to help veterans who may struggle to build their family. Infertility impacts 1 in 8 couples of reproductive age, as well as the LGBTQ+ community and single people who choose to parent. Infertility affects men and women equally and is a disease of the male or female reproductive tract, which prevents the fertilization of sperm and egg or the inability to carry a pregnancy to delivery. There are many causes of infertility, and in some cases, physicians' diagnosis is unknown. Most infertility cases, 85 to 90%, are treated with conventional medical therapies such as medication or surgery. For those that need advanced care, such as in vitro fertilization or IVF, that is the standard of care for complex cases of infertility. IVF is also used when a person needs donated eggs, donated embryos, or needs the help of a surrogate to build their family. IVF is mainstream care for a widespread problem, the inability to reproduce. H.R. 1957 also allows covered veterans access to standard fertility preservation services. Fertility preservation is the preserving of sperm, eggs, or embryos before a medical intervention which can cause future infertility. Common medical interventions include radiation or chemotherapy for a cancer treatment, surgical procedures, and many medications. The American Society of Clinical Oncology has clinical guidelines that require oncologists to advise patients of their risk of future infertility and the need to preserve their fertility. The VHA should not only be advising its covered enrollees of their risk of future infertility, but allow access to those fertility preservation medical procedures. H.R. 1957 would finally give veterans the ability to access the standard of care for fertility preservation. The VHA is a healthcare system for our nation's veterans. However, it is not able to provide care for a common condition that is about building families for our veterans. It is time to right this wrong, allow the VHA to provide care that is needed and wanted, and allow our veterans to build the families they desire and deserve. Our veterans have waited long enough for this gap in care to be fixed. We stand ready to work with Congress to get H.R. 1957 passed as quickly as possible. Thank you.
Thank you very much again for your testimony. And I now recognize myself for 5 minutes. And Ms. Kalura, my first question goes to you. And first, I just want to thank you for pointing out in your testimony about those who are infertile because of another procedure that has been taking place, whether it's chemotherapy or radiation or whatever it might be. And I think in my bill, we're saying if that's the case, then IVF treatment should be available to those. So I thank you for pointing that out. For veterans with infertility that's not service-connected and therefore not covered by the VA, those veterans typically have to pay nearly $13,000 out of pocket per attempt at a family. In the United States, women who access IVF are more willing to risk multiple pregnancies by literally putting all their eggs in one basket and transferring multiple embryos in as many attempts as that they can afford. This puts the pregnant person at risk, puts the pregnancy at risk, increases complications for newborns, and increases overall healthcare costs. So there's a long-term study of Quebec's universal coverage of single embryo transfers found that such coverage dramatically reduced multiple births and overall healthcare costs. Is that a true statement from your perspective, and if you can expound on that?
Yeah, so there's two issues there. The first is the clinical guidelines around how many embryos to transfer in an IVF cycle, which is the standard of care today is a single embryo transfer. There are cases where a physician will work with the patient to transfer more than one embryo, but in most cases today, IVF cases, you're going to see a single embryo transfer. In fact, the Centers for Disease Control is required by federal law to cover or to track every single IVF cycle in the United States and its outcome. And you can look and see the number of IVF cycles that are producing multiple births and even twins, and how dramatically reduced that is and how low it is today. So it really is truly a dramatic change in how care is delivered. Your first part of your question was regarding the out-of-pocket costs and the decision-making of patients who are having to pay completely out-of-pocket for their care. And you characterized it actually well in that it produces poor outcomes when a patient is having the financial stress of dealing with an IVF cycle. We now have data that show that a comprehensive IVF benefit produces better health outcomes. We know this because many states have IVF insurance mandates, and we have a lot of employers who voluntarily offer that care to their employees. It's actually one of the top benefits that employees want today, and we are seeing care that is smart and is a whole health of the woman and the resulting child. So certainly a comprehensive IVF benefit produces better health outcomes.
Thank you so much. And also in your testimony, you spoke about the profound impacts on families who are unable to create a family. Can you talk a little bit about those profound impacts, the mental health impacts?
Yeah, an infertility diagnosis for many of us is life-altering. It impacts not only our health and our relationships and our finances, our spirituality, but our mental health. And again, lots of data showing the mental health impact of an infertility diagnosis. There's been data showing that it's as impactful as a cancer diagnosis. It is, however, silent and stigmatized. And so many of us are suffering without the outpouring that you would get with a cancer diagnosis, for example. So it requires mental health support, peer support, and a supportive community that is going to really hold up that person and that couple as they go through this journey. It's a very windy path to family, and so you're going to need perhaps years of mental health support on that journey.
Very good. I've run out of time, but if the other witnesses could just affirm that the profound impacts, the mental health impacts on your membership relative to infertility is great. If you could just confirm that that's a sentiment within your organizations. Mixed church? Yes, agree.
Absolutely, ma'am. As somebody who has not been able to carry a child myself, this has deeply impacted my mental health.
Thank you very much. I now go to Mr. Rosendahl for 5 minutes of questions.
Thank you, Madam Chair. Ms. Howe, it's so great to see you again. We're gonna get you comfortable with attending hearings, and this is the only way to do it. So I promise I'll ask you what I think are some fairly easy questions. I am really pleased to hear that the number of veteran suicides are going down. The number used to be 21. We had Mission 21, and everybody was working on this, and it's good to hear that they are going down. However, I want to get down to the crux of it. Do you know the percentage of veterans that are taking their lives that are not even service-connected?
Sir, thank you for that question. It is absolutely critical to have that information, and I do not know that number for you, so I will take that back to leadership for the record.
Does anybody happen on the panel to have that? Because it's my understanding that's a very large percentage of the veterans that are taking their lives are not service-connected at all.
Thank you for the question. You are correct. That is a question mark we all have. And by adding that VBA information into the annual suicide report will possibly give us a more clear answer to that question. Just by looking at maybe who is actually applying for that service-connected disability, who has been denied that service-connected disability, and those who may have appealed the service-connected disability.
Okay, so then, and I'm going to open this up then to the panel. The next question. Has anybody conducted any kind of surveys or collected any data from the veterans that are not service-connected, okay, that possibly could utilize some mental health treatment? What is those barriers? What is keeping them from reaching out to the VA and getting this help?
So, great question. I would I would just say, I know there's been some research that VA has done with regard to women veterans, especially along those lines of why haven't you used the VA healthcare system? And we know the women veterans that are using VA healthcare system are high users of care, and especially high users of mental health services. So some of the things, though, that women veterans have indicated, or the research has indicated, is that, if they don't have a welcoming, open environment, or they have a bad experience in utilizing VA, they may not return, and they may be the person that most needs that access to that care. They may even be eligible for service connection, but because they're not going in for care, it may be related to a sexual trauma. There's a variety of reasons. So again, we know that so many veterans don't use the VA healthcare system compared to those who do. And I think, Julie pointed out, those that do use it and access VA's great mental health service, very comprehensive package of services, often fare better. And so it's essential that we get that word out, and those that need it have access to that care.
Very good. So,
And Congressman Rosendale, I'll offer, excuse me, I'm on TV.
Sure.
I'll offer that discharge characterization is also a barrier to access. Folks who have been discharged under policies like Don't Ask, Don't Tell, or for self-medicating their own trauma also experience disparities to accessing that care just because of the character of discharge that they hold.
And that is a conversation that we were having last week about actually managing the discharge much better than is currently taking place. So my question is, if we're losing 17 veterans a day, that is tragic. I have to believe that is the largest loss of life that takes place right now is through suicide, not through other diseases or problems that veterans may be experiencing. And if that is the case, unfortunately, what we hear today is that the VA has opposed H.R. 6273, the VA Zero Suicide Demonstration Project Act. And if this is the greatest loss of life that we are experiencing, couldn't we agree that maybe that should be moved up, 6273, to try to address this suicide rate? Shouldn't we be moving that up on the priority list of legislation that we should be trying to pass through this body?
Listening to VA's testimony and being very respectful of Dr. Miller and his colleagues that were here today, it sounds like, we're hoping the committee can work with VA on some of the issues that they have with the proposed legislation. But reviewing it, certainly, suicide prevention has been a focus of Congress, a focus of the veteran community, and I think we've seen over the last year or more really looking for new ways. And so if this is a new opportunity to look at a program or a system, a model of care, comparing it to what VA does, which they have very comprehensive number of services, and VA is great at research and evaluating. So, if there's a problem with the legislation where they think that it can be improved, hopefully they will work with the committee and that can be, amendments could be made to make it.
Sure. So not to put words in your mouth, but that would be a yes, we should prioritize it?
Yes.
Thank you. Madam Chair, I yield back.
Thank you, Mr. Rosendale. Are there any other members who are here? No other questions. I think I would, before we end, and I know we're also running out of time, if there's something that we just have not highlighted in terms of a question to you, I'll ask you to raise it. Any issue that you feel like we haven't covered with the first or the second panel, as well as your own panel. Anything that we haven't covered?
I just want to quick.
Just speak up.
I just wanted to continue off the question that Joy had answered so very well. looking at some of the pieces of the Zero Suicide Demonstration Program, there's things in there that VA can definitely take and implement, such as reaching or touching that touch point every time a veteran goes to an appointment. A veteran will see a PCP maybe twice a year at the minimum, and that's only 2 screenings. But they may see a pulmonologist or an oncologist for a cancer diagnosis. And having that touch point and just trying to start that conversation during the beginning of their appointment and getting an idea of not only where they stand physically, but also mentally will benefit that appointment they have with that provider so much better. And so far, just bringing that veteran in, making that touch point, possibly bringing in resources or approaching those resources to that veteran.
Thank you.
And I'd like to touch on 2 issues, Congresswoman Brownlee, if that's okay.
Yes.
The first was Acting Ranking Member Rosendale asked a question about how HR 345 would empower women and birthing humans to empower folks. From minority communities, oftentimes folks don't know their rights, and is one of the biggest reasons why people are being involved with justice system or don't have access to the things that are critically available to them. Having access to information only empowers people to know their rights and what's available to them, and will empower women veterans to make stronger decisions for them and their families. The second is that Ms. Johnson mentioned that vets, there was a number that she didn't know, and that was the number of vets who don't apply for IVF or any type of reproductive care. I'm one of them. I know full well that I am not eligible for VA's care. I am 100% service-connected disabled. I'm missing 3 inches of ribs as a result of my service. I am not the person that should be carrying a child because it would probably destroy me. And my wife is not eligible for care either. So it doesn't matter which angle or which approach. No, folks like myself are not even close to included in any of the regulation. And so expansion of these services is imperative for folks to be able to plan for their families. I spent thousands and thousands of dollars just to access IUI services for my wife to be able to carry our child. That's a disservice to veterans and the people who have served our country, and expect those benefits to be extended to them.
Ms. Colora?
Yeah, just want to make a point about how people choose to build their family. And there was a comment made earlier about potentially using embryo donation as a family building option. And at Resolve, we support all ways to build your family. Full disclosure, I'm an adoptive parent. That's how I chose to build my family. Medical treatment, however, should be available to our veterans through their healthcare system. If those veterans choose to not build their family that way, then they can avail themselves of another option. But that availability doesn't even exist today, and so that is why we are so supportive of HR 1957. Thank you.
Thank you. Ms. Elam, any further comments? No, very good. Very good. Well, I thank all of you for being here today. I appreciate it very, very much. I think, the discussion around all of these bills have been extraordinarily important. Mr. Rosendale, I'm going to make a few closing comments, but I'll ask you if you have any closing comments, and we'll then adjourn.
Yeah, I just would like to echo your remarks and thank everyone for participation today. It's great. We can't function in a vacuum, and so everyone that's participated, whether virtually or here live, I just want to thank you so much for taking the time out of your life to help us work on these things. Madam Chair, I yield back.
Thank you very much. And I guess my last parting comments are around the 2 of my bills that are in this package. And the first one around abortion counseling, I look forward to working with the VA to fine-tune the language on that so that we get it right and there's no confusion. And secondly, I just implore the VA to reconsider this bill, all parts of the bill, to look at infertility as a disease and must be treated like any other disease as we do in the VA, and to recognize that 1/3 of infertility diagnoses are unexplained, and we should fall on the side of what's going to be favorable to the veteran versus not. And third is to recognize the mental mental health impacts on veterans and their families. I mean, we spend a lot of time in this committee talking about mental health and suicide prevention, and here we are with an issue of a smaller population of veterans, but who very well are suffering from mental health and maybe even considering suicide. And so this is, to me, a straightforward, easy fix to, resolving that issue for the men and women who have served our country and really put their lives on the line for us and for our country and for our freedoms and liberties. So I just think that that's extraordinarily important. And lastly, I will just say, I think, through this testimony, and I think it's pretty clear that if cost is the issue here, it's really insignificant in the bigger picture of things. So I just implore the VA to take another look at this bill, all of the implications. I know that part of the bill you're taking a good hard look on, but to look at the full bill and its implications on our veterans and their families. And again, I thank all of you for being here. And with that, I know there's something I'm supposed to say. So yeah, with that, all members will have 5 legislative days to revise and extend their remarks and include extraneous material. Without objection, the subcommittee stands adjourned.